Here we have the heart in lower right. So blood's going to go from the atrium, past the AV valve, or on the right side of the heart, past the semilunars, into the lungs. Picks up oxygen. Back here on the left side, this is your patient's left side, left atrium, left ventricle, into the body. Now watch, after the ventricles contract, the blood's going to just briefly drop down, feel these cusps, and that's when we get that dup sound. We can hear it with a stethoscope. It's kind of a dup, dup. The AVs are closed at this point, but you'll see in order for blood to flow from the atrium into the ventricles, pressure changes, AVs open, and when the AV snaps shut, you get the lup sound. Lup dup, until we die. We need 20 minutes of exercise 3 to 5 days a week. And this is not just so we can wear a bikini or swimsuit on the beach. It's to maintain our cardiovascular system, because it's required for cardiac output, the amount of blood our ventricles pump per minute. And we need that for the glucose and oxygen and removing toxins from the whole body, all the way down to the toes. Physiological Cardiomegaly. This is when someone's in great shape, generally, and their heart enlarges, and you can see to the far right the hypertrophy of the myocardium, the major muscles of the heart. Now, it seems like, well, they must pump lots of blood, but their stroke rate is slower. So they might only have 40 to 60 beats per minute, which is called bradycardia. So their volume is about the same as just a normal person. It's just their heart is not working as much. A lot fewer beats per minute. If you have pathological, which pathos means disease or suffering, then we have hypertrophy, but unfortunately there's not a resting phase during the diastole. And so we often see this in hypertension. I mentioned pathology or disease. Stenosis, we have narrowing of the heart valve. In insufficiency, stenosis is failure. Let's just look to the lower right. Sometimes a picture's worth a lot of words. Here's the way it should look: open, closed. Prevents backflow of blood. Here we have stenosis where there's a gap. This is a semilunar or aortic semilunar valve. We may have mitral valve prolapse, and if you look to the far upper right, you'll see where the mitral valve is sort of extending into the atrium. We don't want this. So there's going to be a little regurgitation, a little bit of backflow. And a little bit's okay, a lot's a problem. The stenosis can be taken care of through a replacement valve if it's severe enough. What causes it? Well, bacterial infections sometimes trigger an autoimmune response, and we have something called rheumatic fever. But yeah, it's interesting. Sometimes an infection, like an infection in the foot, for someone who's immunosuppressed, may lead to an infection in the valve. So there's some bizarre connections there. Ischemia means not enough, and not enough blood. So myocardial, we know the myocardium is the major muscle of the heart wall. So the heart wall's not getting enough, and emia means blood. So that whole word pretty much describes the problem here. We call it hypoxia because low levels of oxygen, and that may cause the cardiac cells to produce angina pectoris, which is generally a pressure on the heart. Sometimes feel like there's someone sitting on your chest, or you have pain radiating to the wrist, but not always. Sometimes the person feels nauseous, or they have backaches. So not everyone feels the classic chest pains of angina. Myocardial infarction. Infarct means to die. So again, we look at the word, something about heart muscle dying. And that's what a heart attack results in, because look to the far right. Here you see ischemia first, and now you see a complete obstruction. And that means all the tissues downstream are not getting blood, and they're going to die, infarcted. And they're replaced by non-contractile tissues. So So that's going to definitely diminish. So this region here down below, that part of the heart is no longer going to contract. So that's a left side ventricle, which means blood is not going to be pumped to the aorta as it should. And that can cause problems. Sometimes a massive myocardial infarction can result in a disruption of the cardiac conduction system. So here we have an ECG. You can see this fibrillation here, VFib, and the heart's not able to fill with blood, and now it looks like they restarted the heart with some AED paddles, and we have a QRS wave, maybe, looks like. This might have worked. A murmur can be just clicking, rushing, or gurgling sounds. Often not serious, especially children. Children are often have a little bit of a murmur. But if it's something like a mitral valve prolapse and there's a lot of regurgitation backwards, then we have a problem. CAD is the leading cause of death for women and men in the U.S. Coronary artery disease. And I'm going to go through the steps of it. So I'll be talking about these plaques. And the silent killer bit is that we don't know we have the problem at first because the blood is still flowing. It's just the passageway is getting more and more narrow. And in time, we're going to suffer from angina, fatigue. I'll explain why all these things happen. So let's start with the process here. A lot of words, but the concept's pretty simple. Floating in our bloodstream are these triglycerides, which are fats, and they're covered with proteins. Look at the word, lipo, so that's fat, protein. Two types, the low density, these are the lousy ones. Their job is to transport cholesterol from the liver to the body cells. The high density, I call these the heroes, they're going to remove cholesterol and send it to the liver for elimination. The problem comes in, look at the far right. I know it's kind of a complex image, but let's simplify it, okay? Here we have LDLs. They're passing right through the blood walls of the blood vessels. So here they're moving into the walls. We have macrophages. These are our own body cells that are going to consume these, and they eat so many that they become foam cells. They just kind of stop moving and form this fat streak. And then the body's going to cap this whole fat streak off with some smooth muscle cells. And unfortunately, now that fat streak is going to stay in place. And you see the results of the fat streak here is a bulge in the wall of the vessel. Now, if we keep getting bulge after bulge after bulge, you can imagine the diameter of this blood vessel, the lumen it's called, is going to diminish, and to a point that we start getting that angina. Well, one of the indicators of this atherosclerosis is C-reactive protein, because we have wide-scale inflammation through our cardiovascular system, and so a blood test will show high levels of C-reactive protein. When you see that, and it can also, I'll tell you, C-reactive can also be other reasons, but if someone who's at risk, then it's an indicator of many fat streaks in the walls. Homocysteine also is an indicator in the blood test. It tells us there's been a lot of blood platelet plug forms here. We can have two results from thrombus. We can have just a blockage, a thrombosis, like a deep vein thrombosis, and you don't have to be old to get these. Or a piece of the thrombus may break loose, and we call that an embolus, and it may float downstream and cause problems. Pathos means suffer or disease. Congestive heart failure, CHF. This, I've set the stage for this because I've talked about what can happen if we have a myocardial infarction and some of the myocardium is dead, and then we have a thickening area here. Then there's lower, look at the volume here. Compared to a normal heart, the left ventricle is really large, because remember that blood's being pumped all the way to the fingertips and the toes. But in someone with CHF, overdeveloped hypertrophy myocardium, and add to this perhaps a weakened, like if some of the tissue's dead or the chambers are thin, either way, we have problems, because now blood is going to flow backwards. Diastolic's not as common, and that's where the heart just doesn't fill up with blood because of some defect there. Some of the results is you get edema. You see the swollen ankles. You'll see this especially in some of the senior centers. Also, they'll be coughing a lot, and they get sick because there's fluid that backflows into the lungs, and respiratory infections. The ways that we can identify CADs with electrocardiogram, ECG, we looked at those before. That's where you have the P wave, a QRS, and a T wave. In this case, we do a stress test where we hook them up to a monitor and almost always measure blood pressure as well. We got to pay close attention to these patients because some of them are at high risk. In fact, in some cases, we just inject them with chemicals that simulate this whole stress test without having them do any walking. Radionuclide images involve injecting radioactive nuclides. And here we have, you can see a little ischemia. The blue areas mean no blood. Right? Red areas refer to high blood supply. Echocardiogram is, we don't just use this for prenatal, for looking at babies. We can also look at a heart and determine the volume and velocity of blood that's being pumped. And we can see the inside of the heart, so we can see the chambers of the ventricles and the atria. Electron beam computerized tomography, which is relatively new, but it's a simple process because we're just looking at calcium, because calcium almost always is one of the components of our atherosclerotic plaques. All right, because calcium is carried in the bloodstream and it's deposited there. A cardiac catheterization involves a long, flexible, radiopaque, which, let's see, yeah, this will work right here. And we can, there's often a fiber optics involved in there, and we can see what's going on. And in the case of angiography, we can also inject a dye, and that's what they're showing here. And that radioactive dye can be picked up on a monitor, and we can see exactly where the thrombus is, or the blockage. And sometimes a clot-busting medicine is dispersed as well, and so we can break down some of these clots. So it's not just detection, but we do a little treatment as well with that angiography. A bypass is where we're going to take a vessel from somewhere else in the body, sometimes the saphenous vein in the leg, but also the symptoms in the arm. And we're going to bypass an area of blockage. You can see a little blockage here. So we're going to take it straight from the ascending aorta and stitch it in inferior to the site of blockage. Percutaneous transluminal coronary angioplasty is where we insert a catheter. So we've kind of been through the catheter story once. In this case, a balloon is inflated. And I like this image to the right. This is how it looks in a cath lab. If you ever get the opportunity, sometimes it's kind of tedious because a lot of the time is just spent trying to guide this catheter through the coronary arteries of the heart. And see, in this image, you can't even see the heart. The heart's here, but it looks invisible. You just see ribs and some dark spaces. But this is a coronary artery, and we're pressing down the walls, and we don't want those walls to become sites for deposition later on. And so a stent is put in, and these stents are often coated in a special sort of anticoagulant, anti-smooth muscle chemical so they don't get clogged up. The old stents would just get clogged up, and 3 or 4 months later we have a problem. It's come back on us again. What if you need a heart? In the old days, we would put it on this sterilized ice and put the patient on a heart-lung bypass machine and sever the vagus nerve, and that still happens. The problem with this vagus nerve excision is that they're going to have tachycardia the rest of their life. But nowadays we have devices that can keep the donor heart alive and warm and beating. Really neat. Immunosuppressant medication, well, that's a trade-off for being alive.